Hello to everybody. The title of my talk today is Comparing Treatments in Female Sexual Dysfunction. Here my disclosure of interest. I'd like to start with this funny cartoon just to underline the fact that the study of women's sexuality has been complex. And we have since a long time effective drugs that are capable of improving erection in men, whereas it's quite recent that we had drugs approved for women. And this is due to the fact that we have learned over the year how complex it is to study and investigate the mechanism that allow us to have a healthy sexual response. We know that genetic and epigenetic determinants may influence the ability of women to respond to internal forces and internal incentives. We have a threshold that is within the central nervous system, but also at the level of the genitals, that is different according to many factors. The balance within the central nervous system is mediated by excitatory and inhibitory factors, and this is influenced by many aspects in the biopsychosocial model. So in women, this issue is quite complex, also because we have the hormonal factors, and different periods in reproductive life may affect the sexual response of women. Indeed, as you can see, the endocrine milieu is capable of influencing the neurovascular and neuromuscular substrates of the sexual response in terms of desire, arousal, and orgasm. We know as well that the endocrine milieu is capable of influencing well-being of women, and all these organic factors interact as well with the intrapersonal and interpersonal determinants. So the response in women is quite complex, also because we have to take into account that women, they are receptive to partner stimuli, meaning that of course they can have a spontaneous sexual drive that is strongly related to the hormonal milieu, in particular the role of testosterone, and they can enter the sexual response in terms of all the different phases: arousal, responsive desire, and therefore congestion and lubrication in the genital, orgasm and satisfaction. But as you can see here, emotional intimacy, so everything that is coming from the intrapsychic and interrelational world is essential to give women the motivation to enter the sexual response another time. And in this circle we may observe negative aspects, because for example, if women experience some kind of pain during sexual intercourse, sooner or later they will develop low sexual desire, and so there is a negative vicious circle that will impair sooner or later all the other domains of the sexual response. When we study all the different disorders that we can face in clinical practice, we rely since a long time on the manual for psychiatric disorder, the DSM-4 criteria, and you recognize here all the different dysfunction that we were studied. Why I'm mentioning this classification? Because we have tested all the drugs that we have on the market nowadays according to this classification that identify female hypoactive sexual desire disorder, female arousal disorder, female orgasmic disorder, and then pain disorders, including dyspareunia and vaginism. Nowadays, we have a new version of the DSM, the version 5, and in this version, the expert merged the two diagnoses, female hypoactive sexual desire disorder and female arousal disorder, in one single diagnosis, the so-called female sexual interest and arousal disorder. This complicated a little bit our ability to test drugs, and this is something that is not well accepted by all the experts in the field, because we believe that to try to explore the effect of drugs, we really need to have tools, psychological tools capable of giving us this kind of diagnosis. And at the present moment, we don't have so many of these tools, and so we need to rely only on interview. In any case, it's always essential to remember to everybody that to label a symptom as a diagnosis, we really need to be able to demonstrate a personal, so an individual distress for the woman, or an interpersonal distress in terms of couple relationship anytime, 75%, 10% of the time to make a diagnosis of female sexual dysfunction. The symptoms should last at least 6 months, should not be better explained by another mental disorder, such as, for example, major depression, should not be the consequence of a severe relational distress, such as partner violence or other significant distress. And also we have to rate the severity of the dysfunction, mild, moderate, or severe. It's very difficult to start a conversation in clinical practice, but it's mandatory in women of any age if we want to meet the challenge to diagnose and treat female sexual dysfunction, and in particular hypoactive sexual desire disorder. Together with my collaborators over the year, I try to summarize all the barriers that we see in clinical practice to discuss sexual health during office consultation. We have barriers related to the patient, for example, the age, education, the fact that the woman doesn't have a partner, but also embarrassment and poor awareness. And this is true also for the doctors. We feel not at ease in discuss intimate topic, also because sometimes we perceive we don't have adequate training and we don't have so much time in the office. And also doctors, they fear a little bit confidentiality. But also there are other aspects. They are in the culture. For example, nothing that can be done medically. People that believe that sexual problems are part of the natural aging process. Sex is not a priority in healthcare, and as we said at the beginning, men are from Mars, women are from Venus, and even that only rich people can afford therapy for sexual problems. However, education of women's and healthcare providers is really a fundamental step, in our opinion, in sexual medicine to dispel myths, overcome barriers, and acquire skills. Sexual history and sexual counseling should be part of every consultation across specialties for an effective management of sexual problems in women and in their partners. How we can do that? Sexual counseling is not so difficult, and one of the models that has been proposed over the year is the so-called PLICIT model. You see here permission, limited information, specific suggestion, and intensive therapy. It's very important to rise and discuss the subject, to include information about the sexual problem or about resources that women can find in order to have a better picture what they are experiencing. Also, we may refer to advice regarding AIDS, self-help book or technique the patient can try, and we can provide to our patient some advice referring to specialists with experience in sex therapy. A clinician can provide care at the various levels in this model, and you have to feel comfortable to practice what you're able to do. And just to break the ice with your patients sometimes is enough to help them to cope with these sexual problems. As I told you, the hormones are the one that have been studied more because the hormonal factor in women has been recognized extremely important, and this has been studied mostly at the time of menopause. So we recognize the impact of hormone therapy for these women. Whereas premenopausal women, they cannot follow any hormonal strategy nowadays. We know that transdermal testosterone is the most effective hormonal treatment to improve sexual function and hypoactive sexual desire disorder, especially in surgical menopausal women. They lack the ovaries, so they have a clear androgen insufficiency syndrome. But unfortunately, safety issues have limited the use of testosterone. We know as well the local estrogen therapy is the first-line strategy when sexual symptoms are associated with vulvovaginal atrophy, a condition that is strongly related to the lack of estrogen. And as well, we have a new drug, ospemifene, a selective estrogen receptor modulator, that is a new treatment approved for dyspareunia and VVA, both in the United States and in Europe. Very recently, we have also a new drug, prasterone, that is DHEA, that we can use topically, but it has been approved again only in postmenopausal women with vulvovaginal atrophy and female sexual dysfunction, and has a very favorable safety profile in women with contraindication to systemic hormone therapy. And the DHEA has been also proposed systemically, but we don't have enough level of evidence. But we have many challenges, as we said, in prescribing pharmacotherapy for female sexual dysfunction. And being aware of this challenge and keeping in mind what I've told you at the beginning, that female sexual dysfunction are multifactorial, this is a key element to really meet the challenge in prescribing pharmacotherapy. Why is this? Because a meta-analysis that included 24 randomized controlled trial and with a placebo arm documented a strong placebo effects, more or less present in 2 out of 3 women that were treated for FSD. And as I told you, this is related to the intrapersonal and interpersonal factor that can play a role in the perception of the effect of a drug. And so these findings support the idea that in the scientific world that pharmacological intervention, both in pre- and postmenopausal women, they may have a little clinical efficacy. However, in my opinion, this is not really true, because results were obtained by calculating the rate of improvement only on one of the validated endpoints in clinical trials, the female sexual function index score, which is really unable to capture the full range of sexual behavior specifically related, especially to hypoactive sexual desire disorder. And in addition, the statistical methodology did not consider the effect size, which measured the magnitude of a given intervention in comparison with placebo and other treatment, without confirming by sample size. The comparison of effect size for medication and placebo by using the main measure of sexual desire and distress indicated, when we observe really this meta-analysis, that the median differential effect size was almost double for medication we have on the market. They are flibanserin, we will see in a minute, bremelanotide, and transdermal testosterone when compared to placebo. And in addition, these results are in line with patient-reported outcomes on meaningful clinical benefits with drugs over placebo, and collectively suggest that we should reconsider study design, validated endpoints and instruments to really assess the clinical significance. However, it's very important to follow a process of care for the management of hypoactive sexual desire disorder. We really need to ask permission to discuss the issue. We really need to ask a very simple question to our patient: are you sexually active? Are there sexual concerns you wish to discuss? And if women, they report hypoactive sexual desire disorder, low sexual desire and interest, we can demonstrate if this disorder is generalized, acquired, and so it's due to something that happened in your life, and you can try to remove these modifiable biopsychosocial factor they are there, and to remove a biological factor. For sure, you really need to treat your patient with something. And according that you are premenopausal or postmenopausal, you can propose different drugs: sex therapy, CNS agent in premenopause, hormone treatment, as we said, or other CNS agent alone or together with sex therapy. And sometimes counseling, education, or referral to psychotherapists for lifelong or situational sexual desire disorder is enough. When we consider the level of evidence of the treatment intervention for hypoactive sexual desire disorder, as you can see, psychological intervention have a level of evidence of 2, whereas the pharmacological intervention, the 3 I mentioned before, they were comprised in meta-analysis: flibanserin, bremelanotide, and testosterone therapy. They have a level of evidence of 1. And if we focus our attention on this psychoactive agent, flibanserin and bremelanotide, and we remember the cartoon I showed you at the beginning, you may easily understand why this psychoactive agent, they can be effective to treat hypoactive sexual desire disorder, because you recognize the 2-box excitatory and inhibitory pathways regulating the sexual response. And I want to remind to everybody that normal sexual function relies on the proper balance of excitatory signals. They are regulated by dopamine, norepinephrine, oxytocin, and melanocortin, and inhibitory signals. They are regulated by serotonin, opioids, and endocannabinoids. And the pathophysiology of hypoactive sexual desire disorder seems to stem from the imbalance of these excitatory and inhibitory signals. It has been hypothesized that HSDD results from an hyperactive inhibitory response, as you can see here, hypoactive excitatory response, and a combination of hyperactive inhibitory and hypoactive excitatory response. And therefore, you see easily what happened in the brain of a woman, and I thank Jim Pfizer for offering me this cartoon, and you may easily understand what happened with flibanserin. Flibanserin is a drug that was approved in 2015 for premenopausal women with acquired generalized hypoactive sexual desire disorder, once daily tablet taken at midnight. It's important, I remind to everybody that in 2019 there was a warning by the FDA suggesting that you may you should pay attention to hypotension and syncope in certain settings, for example, interaction with alcohol. But you see that flibanserin is able to increase the release of dopamine and norepinephrine in the prefrontal cortex, and in the medial preoptic area, an effect on dopamine and norepinephrine, whereas flibanserin is capable of reducing serotonin in the prefrontal cortex, in the nucleus accumbens, and in the medial preoptic area. And so this is the mechanism through how flibanserin works and can improve hypoactive sexual desire disorder. It's however very difficult that women, they take chronic treatment for a non-life-threatening condition that is not covered by insurance, and this is the major barrier that we have to a chronic treatment such as flibanserin. Current studies on pharmacotherapy suggest that there is room for significant advances in the field of treating hypoactive sexual desire disorder, and also non-pharmacological strategies addressing also non-medical variables are valid alternatives that may complement the pharmacological approach. This is the reason why another drug was studied, and this is a drug, bremelanotide, that was approved very recently in 2019 for acquired generalized hypoactive sexual desire disorder. And this is a on-demand drug, so in the hope that women they can accept this kind of drug that you use just on demand. In the clinical studies, women were advised to use bremelanotide 45 minutes before anticipated sexual activity, and the expected duration of action was 16 hours. What is bremelanotide? It is an analog of the naturally occurring peptide MSH, and because we know that this drug is a melanocortin receptor agonist that binds to the receptor 1 and receptor 4 at a therapeutic dose. And at the end of the day, as you see in the cartoon, this drug is capable of increasing the release of dopamine in one site and decrease the release of dopamine in another site. So bremelanotide is acting on the physiological and neurobiological component of female sexual function, and is capable of modulating both the circuitries of sexual desire and arousal in women with hypoactive sexual desire disorder. However, it's very important I remind you that over the years, the lack of approved drugs with a clear indication for FSD has promoted a sexual market of products with no rigorous science-based evidence, both in terms of efficacy and safety. But however, people they use this drug very much because women they like natural strategy to fix a sexual problem. And many substances we have out there, they are suitable candidates to improve sexual function in women due to their pro-sexual properties. Keep in mind as well that not all the symptoms they are so severe they need to be treated with a drug. This is the reason why we decided with my dear friend Alessandro Genazzani to test in clinical practice the potential role of a natural product containing levoarginine, propionil levocarnitin, muirapuama, damiana, together with zinc, black courge, ginkgo biloba, vitamin B3 and genistein in the treatment of women with female sexual dysfunction. This is a drug that is especially designed for active women, which contain all these ingredients. They can provide support for the libido of women, because we know that these compounds they maintain normal hormone level and reduce tiredness and fatigue. We propose this drug one sachet per day for 6 months in a pilot study including premenopausal women with FSD. Remember that in Italy and in Europe in general, we don't have any registered approved drug to treat premenopausal women with hypoactive sexual desire disorder. We designed a two-center prospective observational study in partner premenopausal women, age range 26 to 50. The mean age was 41 years, with FSD documented by using the female sexual function index, and all the women they were under the cutoff for meaningful sexual dysfunction in clinical practice 26.5. We lack a placebo group, unfortunately, but you will see that the results are extremely interesting. Half of the study sample was on COC. Remember that the use of hormonal contraception is a major modulator of hypoactive sexual desire disorder and sexual dysfunction in women. 45% of them they were nulliparous. We study as well sexual distress, anxiety and depression, and personal general well-being. 40 women completed the 3 months treatment and fill in the questionnaire baseline and following 12 weeks of treatment, and only 30 women completed the 6 months. 16 they were premenopausal and 14 they were on combined hormonal contraception. In some cases it was because we lost women at follow-up, and in some cases women, they did not find the treatment effective following 3 months. You see the results, and you may observe that over 6 months, but keep in mind that results are only on 30 patients, so probably we had 6 women that found the compound completely ineffective and they stopped the treatment. But as you can see, if we compare the women that go on 6 months with the baseline, you may observe a significant increase in the total score for the female sexual function index, but also you may observe a significant decline in sexual distress at month 3 when we compare 40 women with the baseline, and even more as expected, because women they go on, they are the one that perceive the benefit at 6 months. When we split our population according to the use of hormonal contraception or not, you see that we were able to find the same results. At 6 months, women taking this product, they improve significantly their sexual function, both in terms of total score of female sexual function index and in terms of distress at 3 months, and even more at 6 months. And this effect was even better in women that were not taking hormonal contraception, but it was confirmed also in women on hormonal contraception. When we analyze all the different domains that we can measure with the female sexual function index, in the group that were not on combined hormonal contraception and on combined hormonal contraception, it was interesting to observe that women on the pill, they had a lot of benefits on all the different domains, whereas women they were not taking hormonal contraception, they had a significant improvement, for example, of lubrication and arousal, and a reduction in sexual pain, because keep in mind that when you increase the sexual pain score means that you have less pain. So essentially in the clinical practice at the present moment, a compound like this one containing carnitine and arginine can do some good in order to complement our ability to treat our patient with female sexual dysfunction. This effect probably is also mediated by a significant improvement in mood and well-being. As you can see here, both the hospital anxiety and depression scale and the psychological general well-being index were affected by this supplement, and women they report less anxiety and depression at 3 and 6 months, and more and general sense, positive sense of well-being throughout the study. So in conclusion, ladies and gentlemen, we have always to follow an integrated biopsychosocial approach. General health practitioners, but especially gynecologists, they face sexual dysfunction in clinical practice very much. They cannot become psychologists, of course, but they have a big role in uncovering the issue, in trying to counsel their patient, and if they cannot prescribe a drug, at least they can give some advice, including supplements. And with this, I thank you very much for your attention.